Welcome to Pediatric Case Review. Today we will explore liver transplantation in children, focusing on advanced concepts for practicing pediatricians. This comprehensive lecture will cover indications, evaluation, surgical aspects, post-operative care, and long-term outcomes using a case-based approach to enhance your clinical application of this knowledge. A 4-month-old infant presents with persistent jaundice, clay-colored stools, and hepatomegaly. Ultrasound shows absent gallbladder, which is the most common indication for liver transplantation in children. Option A, hepatoblastoma. Option B, biliary atresia. Option C, Wilson's disease. Option D, acute liver failure. The correct answer is B, biliary atresia. This condition accounts for 50 to 60% of pediatric liver transplants. Biliary atresia remains the most common indication even after Kasai procedure attempts. Other significant indications include metabolic disorders, acute liver failure, and hepatic malignancies. Early referral for transplantation evaluation significantly improves outcomes for these patients. A 5-year-old patient presents with hemolytic anemia, elevated liver enzymes, and decreased serum ceruloplasmin, which metabolic disorder may require liver transplantation even with normal synthetic liver function. Option A, tyrosinemia. Option B, Wilson's disease. Option C, Crigler-Najjar syndrome. Option D, alpha-1 antitrypsin deficiency. The correct answer is C, Crigler-Najjar syndrome. This disorder requires liver transplantation due to the risk of kernicterus, despite normal synthetic liver function. Other metabolic disorders that may require transplantation include Wilson's disease, tyrosinemia, and urea cycle disorders. Liver transplantation can be curative for many of these enzymatic deficiencies, replacing the missing or defective enzyme. A previously healthy 3-year-old presents with encephalopathy, jaundice, and coagulopathy 10 days after symptom onset. Which laboratory finding most strongly indicates need for urgent liver transplantation? Option A, AST greater than 1000 international units per liter. Option B, total bilirubin greater than 15 milligrams per deciliter. Option C, international normalized ratio greater than 4.0. Option D, ammonia greater than 100 micromoles per liter. The correct answer is C, international normalized ratio greater than 4.0. Pediatric acute liver failure criteria include international normalized ratio greater than 4.0 in children under 2 years without improvement with vitamin K. Other important indications include encephalopathy and progressive coagulopathy despite medical management. Early listing for transplantation is crucial as deterioration can be rapid and unpredictable in these cases. A 7-year-old patient with decompensated cirrhosis being evaluated for transplant has progressive neurological deterioration, which is an absolute contraindication for liver transplantation. Option A, portal vein thrombosis. Option B, previous abdominal surgery. Option C, irreversible brain damage. Option D, controlled extrahepatic infection. The correct answer is C, irreversible brain damage. Absolute contraindications for liver transplantation include irreversible brain damage, incurable extrahepatic malignancy, and uncontrolled sepsis. Relative contraindications include human immunodeficiency virus infection, which is changing with newer therapies, psychosocial factors, and advanced age. Complex vascular issues present technical challenges but are not considered absolute contraindications. A 2-year-old with biliary atresia post-failed Kasai procedure is being evaluated for transplant. Which assessment is not typically part of the standard pre-transplant evaluation? Option A, cardiac echo. Option B, neuropsychological testing. Option C, human leukocyte antigen typing. Option D, nutritional assessment. The correct answer is C, human leukocyte antigen typing. Human leukocyte antigen typing is less relevant for liver transplantation compared to other solid organ transplants. Comprehensive pre-transplant evaluation includes cardiopulmonary assessment, nutritional status, and neurological evaluation. Laboratory evaluation encompasses liver function, renal function, and viral serologies. Psychosocial assessment and optimization of nutritional status are critical success factors for pediatric liver transplantation. A 10-kilogram infant needs liver transplantation, but no suitable pediatric donors are available. Which surgical option allows for transplanting a portion of an adult liver into a small child? Option A, auxiliary transplantation. Option B, split liver transplantation. Option C, domino transplantation. Option D, heterotopic transplantation. The correct answer is B, split liver transplantation. Split liver transplantation allows one donor liver to benefit 2 recipients, with the left lateral segment typically used for a child. Living donor transplantation has become increasingly important in pediatrics. Technical advances have significantly improved outcomes with partial grafts. Size matching remains critical for successful outcomes in pediatric liver transplantation. A 4-year-old, 12 hours post-liver transplant has increased drain output with elevated bilirubin. Which early postoperative complication is most likely? Option A, acute rejection. Option B, hepatic artery thrombosis. Option C, bile leak. Option D, primary non-function. The correct answer is C, bile leak. Bile leaks typically present with bilious drain output within days of surgery. Early postoperative complications include vascular thrombosis, primary non-function, and bleeding. Immediate postoperative care focuses on fluid balance, electrolytes, coagulation, and graft function. Early recognition of complications is critical for both graft and patient survival in pediatric liver transplantation. A 6-year-old post-liver transplant develops tremors, hypertension, and elevated creatinine. Which immunosuppressant is most likely responsible? Option A, prednisone. Option B, tacrolimus. Option C, mycophenolate mofetil. Option D, azathioprine. The correct answer is B, tacrolimus. Tacrolimus is a calcineurin inhibitor with classic side effects including nephrotoxicity, neurotoxicity, hypertension, and hyperglycemia. Standard immunosuppression regimens include a calcineurin inhibitor, tacrolimus or cyclosporine, steroids, and an antimetabolite. There is a trend toward minimization protocols to reduce long-term complications. Therapeutic drug monitoring is critical for balancing efficacy versus toxicity. A 5-year-old, 3 weeks post-transplant, presents with fever, increasing transaminases, and jaundice. What is the gold standard for diagnosing acute rejection? Option A, liver ultrasound. Option B, liver biopsy. Option C, elevated liver enzymes. Option D, response to increased immunosuppression. The correct answer is B, liver biopsy. Acute cellular rejection occurs in 30 to 50% of pediatric liver transplant recipients. Clinical presentation typically includes fever, malaise, and liver enzyme elevation. Management involves pulse steroids for mild to moderate cases and thymoglobulin for steroid-resistant rejection. Chronic rejection requires early recognition and aggressive management to prevent graft loss. A 7-year-old, 2 months post-transplant on tacrolimus, develops fever and pulmonary infiltrates. Which opportunistic infection is most concerning in the first 6 months post-transplant? Option A, cytomegalovirus. Option B, Epstein-Barr virus. Option C, Candida species. Option D, pneumocystis jirovecii. The correct answer is A, cytomegalovirus. Cytomegalovirus has peak risk between 1 to 6 months post-transplant. Cytomegalovirus can cause direct disease or indirect effects, including rejection and other infections. Prophylaxis strategies are based on donor and recipient serology status. The infection timeline includes surgical and bacterial infections in the first month, opportunistic infections from 1 to 6 months, and community-acquired infections after 6 months. Vaccination schedules must be modified for transplant recipients. A 3-year-old post-split liver transplant develops fever, increased transaminases, and biliary strictures. Which vascular complication most commonly leads to biliary complications? Option A, portal vein thrombosis. Option B, hepatic artery thrombosis. Option C, inferior vena cava thrombosis. Option D, hepatic vein stenosis. The correct answer is B, hepatic artery thrombosis. Hepatic artery thrombosis may lead to biliary complications due to the bile duct's blood supply being primarily from the hepatic artery. Monitoring includes routine Doppler ultrasound during follow-up. Early detection is crucial and may require urgent revascularization or retransplantation. There is a higher risk of vascular complications in pediatric recipients due to smaller vessel size. A 12-year-old, 5 years post-transplant, presents with fatigue, lymphadenopathy, and Epstein-Barr virus viremia. Which post-transplant malignancy is most common in pediatric liver transplant recipients? Option A, hepatocellular carcinoma. Option B, post-transplant lymphoproliferative disorder. Option C, skin cancer. Option D, colorectal cancer. The correct answer is B, post-transplant lymphoproliferative disorder. Post-transplant lymphoproliferative disorder risk factors include Epstein-Barr virus mismatch, donor positive, recipient negative, intense immunosuppression, and young age. Other long-term issues include renal dysfunction, metabolic complications, and growth issues. Regular monitoring includes Epstein-Barr virus polymerase chain reaction, renal function, and metabolic parameters. Surveillance protocols are individualized based on specific risk factors. A 9-year-old, 3 years post-transplant on tacrolimus and low-dose prednisone shows poor linear growth. Which intervention is most appropriate to address growth issues post-transplant? Option A, increase caloric intake. Option B, steroid withdrawal. Option C, growth hormone therapy. Option D, increase vitamin D supplementation. The correct answer is B, steroid withdrawal. Steroids significantly impact growth, and steroid minimization or withdrawal protocols are beneficial for improving linear growth. Nutritional optimization and metabolic control are also important factors. Growth hormone therapy may be considered in select cases after ruling out rejection. Regular developmental assessment is critical for pediatric liver transplant recipients to ensure optimal growth and development. Parents of a 2-year-old with biliary atresia have religious objections to blood transfusion during transplant. Which ethical principle is most relevant in this scenario? Option A, autonomy. Option B, beneficence. Option C, justice. Option D, non-maleficence. The correct answer is A, autonomy. This principle relates to parental decision-making and consent. Ethical challenges in pediatric transplantation include organ allocation, living donation, and non-adherence issues. A multidisciplinary approach including ethics committee input is essential. Cultural sensitivity and family-centered decision-making are important considerations. There must be a balance between the best interests of the child and parental authority in these complex situations. A 17-year-old transplant recipient is preparing for college and transfer to adult care. Which is the most significant risk during transition to adult care? Option A, development of de novo autoimmune hepatitis. Option B, non-adherence to medications. Option C, post-transplant lymphoproliferative disorder. Option D, biliary complications. The correct answer is B, non-adherence to medications. Structured transition programs improve outcomes for adolescents moving to adult care. Key components include medical education, self-management skills, and social support. The transition process should start early, around 12 to 14 years, with a gradual transfer of responsibility. Adult providers need pediatric-specific knowledge when caring for transplant recipients who transition from pediatric services. Pediatric liver transplantation outcomes continue to improve, with over 90% one-year survival rates. Success requires a multidisciplinary approach and long-term follow-up care. Thank you for following Pediatric Case Review. Please subscribe to our channel, comment with any questions you may have, and share this presentation with your colleagues. Future presentations will cover other advanced pediatric topics to enhance your clinical practice.